Hello. I know many of you, and I'll just leave it at that in that perspective. But it's a joy to meet those of you, and perhaps later I can meet you a little more so afterwards. But it's a joy to be here. Michelle asked me, and I met with Father probably about a month, maybe 2 months ago, in terms of preparation for this. But after having had so many encounters with your parish through my practice, I mentioned this. I'm a little surprised I haven't been invited before now, because there are so many of you that have asked me if I do these kinds of things, and so it's just actually a joy to come down here. We've been down to the parish before on a couple of occasions, so it's nice to come back, although I did get lost coming here. I wound up at a gas station, and as I was driving in, I was going to ask, where's St. Joe's? There I saw someone selling Tootsie Rolls this morning. I figured he would know. For those of you who don't know me, I'm Michael Dixon, and I'm from St. Louis originally. Meandered throughout the country in terms of training. Married to my wife Kathleen, who's a pediatrician, but works in a different role right now, in many roles. And we have 6 children, 3 of whom are no longer in the home, and 3 of whom are still with us. And I'll explain that here as we go through. I had to modify my talk a little bit. I do have one Calvin and Hobbes slide from her. Yes. But I don't have it with me. So I was going to try to match her Calvin's. This talk is not, as I was driving in, someone had to sign up my name with natural family planning or family planning. And this is not a family planning talk. I will tell you that right at the outset. So I apologize if that's what you came for. What I've tried to do basically is to give you, if you will, a day in my life. What do I see, and how does that impact that which might follow upon what Father has said? Another title of the talk could be Healthcare for Women Without Using the Pill. And although I don't have a slide for this, yet another one which I've thought about doing and modifying this one a little bit would be, if it was a talk to the men, what your wives have told me behind closed doors. Now we're interested. That could have been the title for the talk.
You can come back for the Advent by taillight for the men.
Oh, nice.
And do that sometimes.
Oh, that's good.
That is good.
You guys do that?
Yes, we do.
There you go. Yeah.
That's your
Okay.
next speaker.
As I woke up this morning, I thought of this. I was a family physician and went back into the second residency in obstetrics. When I went back and did that second residency, I realized that it's a difficult area in terms of current medical training. Really accepts the norms of the world in terms of the sexual values, the promiscuity, contraception, the right to choose, which is the euphemism for abortion. We certainly see the alternative lifestyle scenario right now. The stem cell scenario that we dealt with several years ago and still continue to deal with, assisted reproduction, and certainly the HSS mandate at this time from a political perspective. What I learned in residency deals with contraception, tubal ligation, endometrial ablations, artificial inseminations, IVF, postcoital contraception, which is a euphemism for the morning after pill and really abortion, and then actually induced abortion. And of course, we treat all of these with birth control pills. That's the way we're taught. We treat, whether it be ovarian cysts, pain, irregular cycles, abnormal bleeding, all the issues of family planning. Ovarian cysts can also be treated with surgically. Polycystic ovarian disease treated with medications to influence insulin. And endometriosis can be treated in multiple ways. Infertility commonly is treated through medications such as Clomid or through artificial insemination and IVF. So things are murky. in the context of how does a Catholic physician train? And really it's a dilemma that current medical students and residents face because they're looking ahead to going into a profession, trying to maintain their beliefs, yet be accepted in the world. I had the privilege of being in St. Paul, Minnesota last week at the Catholic Medical Association meeting. And this is an organization that flourished back in the 50s and 60s. And then it actually was decimated and went down to about 100 members in 5 guilds throughout the country. In other words, as a result of Humanae Vitae, so many physicians pulled out of this organization. And it's built back up now to over 1,000 members. They expected 400 at this meeting last week, and they were pleased to have 600. But what was even more interesting is that there were 70 medical students and residents there. And that's really the hope for the future. So, Father alluded to this, Humanae Vitae, 1963. And in it, there were 2 paragraphs, paragraph 24 and paragraph 27, that are particularly written to physicians. And basically, and it doesn't show up well, I guess I need to change the color. To physicians, let them consider it their special mission to acquire all necessary learning in this difficult area. Thereby they may be able to give good advice to spouses seeking their counsel and to direct them along the right path. Spouses rightly seek such direction from them. And that is probably one of the key documents that led me to go back in and do the second residency. I have to give credit to the Jesuits because there was a Jesuit priest in my college days in the Theology of Marriage course back in the 70s who actually made us read Humanae Vitae. He was actually the only priest that used Humanae Vitae in the Theology of Marriage course. But that's when I read this, and I was, at that time, pre-med, going into thinking of family medicine, really not even anticipating obstetrics and gynecology. But after reading and rereading this, it is that which propelled me to higher malpractice premiums and less sleep. I have to give credit to my son. My son Paul is, you'll see him here in a little bit, but he's currently a third-year medical student at Dartmouth. And I had truly a sleepless night on Thursday night, and I was house physician, for those of you who are familiar with St. Anthony's. I was working basically for the hospital. And usually you have a decent amount of sleep, but it's one of those nights when I had none. But 2 women had come in. One wound up having what's called placenta previa, and emergency C-section, bleeding, actually eventually leading to hysterectomy. And the other lady had a demise of a child at 20 weeks, and then the placenta wouldn't pass. Make a long story short, both were bleeding quite a bit, and both required surgery. I was discussing this with Paul last night as he was helping me, and the reason I bring this up is that I know nothing about computers. Francis and I have talked about this, but he was helping me prepare the slides. But as I was discussing this, the 2 cases of Thursday night with him, he was all excited because, and I don't know where he's going with his life, but he's on neurology right now, and he said, all I'm dealing with right now are women with headaches and men with seizures. So he wasn't, those are important things too, but he was excited about the surgical side of things. So he may be following in my footsteps. I pray that he does. Priests were also addressed in this topic. I'm sorry, the reason I said that is that he helped me put all this, and I'm amazed at the technology such that he in New Hampshire signed on to our computer at home and helped me transfer all of this to this computer here. I had my 2x2 Chromachrome slides, and I was hoping to bring them. Okay, Father, your first ancestors founded Church's teachings on marriage without ambiguity, and I commend you for doing that this morning. And then bishops were addressed in Humanae Vitae also, to consider this mission as one of their most urgent responsibilities. So the Holy Father at that time realized that he needed help from the bishops, from the priests, and quite frankly, lay couples. All of us are addressed in this as well. In response to that, John and Lynn Billings, he a neurologist, she a pediatrician over in Australia, were simply asked by their bishop, would you do something to help? Because their bishop at the time over in Australia said, okay, the Holy Father's come out with this document, we don't have a way to implement this, and it led to them coming forth with that which has become known as the Billings method. I had the privilege of meeting them back in the early 90s. In following in their footsteps was Dr. Hilders, who I had the privilege of doing a fellowship under for actually a year, I was his partner for a year in Omaha. And basically what he did was to take the initial work of the Billings and to modify that as a gynecologist, it would be a method that would be usable in an obstetrician's practice. Not only helping couples from a family planning perspective, but also to essentially have the continuity of being able to practice obstetrics and gynecology without compromising the faith. With all of that, after my training, after finishing in Omaha, we started our practice in St. Louis on the Feast of the Immaculate Conception in '95. And what do I do?
I can escape.
Just take it. Okay. If it goes right, I'm okay. And since that time, Dr. Stegman was with me for a while, and Dr. Gosser has since joined me, but we've had the privilege of being a part of many of your deliveries in medical situations. And I was told, quite frankly, when I came back to St. Louis, that unless I prescribed the pill and tied tubes, that I wouldn't be able to survive. And it's not me, quite frankly, it's simply a philosophical approach that, don't ask me why, but I saw 3 patients yesterday. None of them knew they were coming, but they were all from Chicago. 3 couples had driven all the way in from Chicago because there's not a single physician in the entire northern Illinois area that practices or understands NAPRA technology. I didn't know how to get rid of the 1 on there, so you're going to see the 1 on the bottom. Just slides from our family vacations. I get to see them every once in a while. So where do we go? What do I see? What I'm going to go through with you right now is basically a series of vignettes of that which I see in the office. And they'll speak for themselves. So, 22-year-old college student comes in with severe left lower quadrant pain at mid-cycle. The 17-year-old high school senior has severe menstrual cramps. The 25-year-old religious brought in by Mother Superior, who has premenstrual spotting, headache, quite a bit of irritability, that was the primary reason, and brown spotting. The 41-year-old mother of 5 who winds up having a positive pregnancy test and the usual nausea, vomiting, fatigue. She's in her parish, very active, pro-life, but she really doesn't want to be pregnant. Perhaps that same 41-year-old mother of 5 who has abnormal uterine bleeding, who has a biopsy that indicates a need for a hysterectomy. At the post-op visit, she's doing well, but she's troubled. She's not sleeping, she's tearful and withdrawn. The 14-year-old chaste daughter whose pediatrician has recommended Gardasil. This is always the question that comes up after I've spent 30 minutes doing a 15-minute well woman exam. The 15-year-old chaste daughter with severe acne, whose dermatologist, because of that acne, has recommended Accutane and won't prescribe it unless she's on contraception. The 25-year-old professional who's been infertile for 3 years and her OBGYN has recommended IVF. The 45-year-old busy wife and mother who has a frustrated husband desiring intimacy and a fatigued wife with no libido desiring sleep. That's the segue for that talk. The wife and mother of 3 who's had a tubal ligation. Or perhaps that same 37-year-old wife whose husband has had a vasectomy. the 31-year-old with her second pregnancy. In the first child was born at 32 weeks with preterm labor. Wife and mother of three. I went the wrong way. A lady with her 6th pregnancy. She's had 5 previous C-sections, and she's concerned about uterine rupture. A lady with 2 miscarriages and has a positive pregnancy test and concerned. The 32-year-old woman who's pregnant, 23 weeks, 5 days, and her water breaks. And I think this is the last one. The 29-year-old pregnant, and on ultrasound, the routine ultrasound, when everybody comes in excited at 20 weeks, we do the ultrasound and we don't see a brain for the baby. Each of those, quite frankly, that's a typical day for me. Obviously, in many respects, all of those could be in the same day, but that's basically the types of things I deal with day in, day out. And contemporary gynecology approaches each of those in a way, if you will, very much different than I would approach it. In this audience, I can say this, but I don't practice the standard of care in obstetrics and gynecology in the context of what standard obstetrics and gynecology currently asks me to do. So, you saw paragraph 27. Paragraph 24 from United encourages scientists to work for the good of marriage and family and to assist their peace of conscience if, with their united efforts, they attempt to clarify the conditions which favor a moral ordering of human procreation. And through this observation of natural cycles of fertility, to strive to establish some basis for this moral regulation of offspring. No true contraindication exists between the divine laws of transmitting life and those of fostering true love, true conjugal love. So if we're talking about nature, we see little critters, we see plants, we see big critters, and more plants, and little critters, and big critters next to small tents, and big mountains, and even smaller critters, and Old Faithful, all coming to the fact that we're not some casual and meaningless product of evolution. And Father alluded to this earlier. The Holy Father, current Holy Father, each of us is indeed the result of the thought of God. And as Pope Paul VI said, the laws of God and the laws of nature can never contradict each other. So what do we do? What do we do? In that context, human nature itself recognizes that, in my specialty, women, for the most part, are infertile. And by contrast, we are usually fertile. And basically, that's male and female in creativeness. If we look at this in terms of the cyclic nature of the woman and the cyclic nature of the woman and the continuous fertility of the man, we then have the combined fertility of the husband and wife. And basically from that, as a result of the changes of the cervical mucus primarily, there is only a window of time in which fertility exists. And as a result of that, each of the different methods of family planning, and it's interesting, after being at this meeting last week at the CMA, there are cities, I mentioned Chicago being one of those. Houston just, well, Chicago is the 3rd largest city, and Houston is the 4th largest city because I trained in Houston. It's just this year that Houston has its first NFP-only obstetrician. But, and I think there's only one or two methods of family planning, natural family planning there. We have actually all 4 of the current methods of natural family planning available in St. Louis. Symptothermal is taught by the couple-to-couple leader. The Billings method is the original Billings method, and that was actually the first one here in St. Louis. The Creighton model and the Marquette model. The symptothermal method was first designed and described, well, actually not first, but it's been culminated in a description in a method initially put forth by Dr. Kipley, who is a theologian. His doctorate is actually a PhD. The ovulation method, we mentioned Dr. Billings, who is a neurologist. The Creighton model was put forth and actually initially founded here in St. Louis by Dr. Hilders and two nurses, Ann Preble and Diane Daly, who still actually are at St. John's Nursing. And the Marquette model by Dr. Ferring. Dr. Ferring actually has a PhD in nursing. So of those, and it's the one that I use the most in my office, only because it's the medical model that allows me to combine my personal faith in obstetrics and gynecology. We see some slides here of what would be changes in temperature, where a woman using the couple lead will have temperatures that are lower. As a result of ovulation, the temperature rises, and if combined with symptoms, one can identify the time of fertility. Here we see an actual couple lead slide showing also that what's called a biphasic shift, where the temperatures are low, then high. Many descriptors here, and essentially allowing the woman in a very detailed fashion to identify the time of fertility based upon the symptoms of her body, the mucus, the temperature, the cervical changes, along with, as I said, the temperature. The Marquette model is predicated upon use of a monitor that uses daily urine testing, and through that monitor one can identify the LH surge which occurs, and we see the time of fertility and peak day being identified through this rise in luteinizing hormone. Complex, expensive, but it works. And then the Creighton model, that which is taught, actually it's taught in all the hospitals here in St. Louis. We probably have more teachers of Creighton model in St. Louis than I think even in Omaha right now, where it's home base. But it's that which dovetails with nanotechnology, which I'll discuss. Just to comment there, and I alluded to this also, we were privileged in St. Louis to have, and it came forth again last week at the CMA meeting, there are 14 Catholic OBGYNs in town who practice according to this NFP only approach. One gentleman's retired, Dr. Donham. Doctors Brennan, Gossert, and myself are in South County. We're all at St. Anthony's. There are two other physicians up at St. Mary's, Dr. Lefevre and Dr. Young, both in restricted practices, so to speak, in the context that Dr. Lefevre, who's quite focused in the area of vaginal and vulvar disease, but only practices 1 day a week. She's also a full-time mom, homeschooling mom. Dr. Young has just come back to St. Louis, and I'm particularly impressed by him in the context that he only works in the area of endometriosis, but is trying to do it somewhat in a, if you will, a secular approach. He has come in, holds his faith, but hasn't really waved the Catholic flag, so to speak, at St. Louis University. So he has a way of actually getting in, going behind enemy lines, if you will, at one of the teaching hospitals in St. Louis that you can guess, and it is basically simply trying to establish himself, and has been here now over a year, in the area of endometriosis. Dr. Stegman is back in St. Louis, and then what we have are 7 residents up at St. John's in training. So it's exciting to have that many young residents in training. Dr. Hilder's own daughter is one of those residents right now. She's a first-year resident. Okay, I'm not going to bore you with anatomy slides, but there are just 3 or 4 here. This is what I deal with every day. Ovaries that contain roughly 400,000 eggs at birth, one of which is released per month. That whole process of ovulation is depicted here in terms of the increasing size of the follicle, eventually leading to a rupture of the egg through the surface of the ovary, leading to the formation of the corpus luteum, which makes progesterone, and these little follicle cells, which make estrogen. So in a nutshell, and those of you that I've seen in the office have probably seen this, that the source of estrogen is actually around from these cells around each of these follicles, and it's month-long, whereas progesterone is only produced for roughly 2 weeks of the month. And we see that here in terms of the rise in estrogen that occurs. It's this rise in estrogen that parallels cervical mucus, and it's why the mucus-based methods allow us to predict that ovulation is about to occur. The temperature-based methods are predicated upon the fact that progesterone causes a woman's temperature to rise. So they are retrospective in their approach, in that they allow a woman to know that she has ovulated. I spend much of my time dealing with these hormones, whether they're being too high, too low, and almost often they're too low, and all the implications of bleeding problems as well as PMS from this, as well as progesterone in pregnancy. The lining of the uterus, the tissue sloughs, it builds up under the influence of estrogen. Ovulation occurs. When ovulation occurs, there's a change in the lining which allows for little babies to implant roughly 7 days after ovulation. And if indeed the nest is prepared, so to speak, the young zygote, now, the young baby, now 7 days old, will implant here and live for the next 38 weeks, 37 weeks at that point. If there is no pregnancy, then the lining sloughs, and you start